Okay. Oops. All right. Good morning, everyone. My name is Adati Tarfa, and I'm a student in health services and policy research in the School of Pharmacy. And today I will be talking about my master's thesis project, which I defended last year, but I'm in the stages of writing my manuscripts and also developing my dissertation topic. So I'm grateful to be here and hear your input. So I will go ahead and start. Can you see my screen or have I not? No, let me share. All right, so I will be talking about the perspectives of stakeholders regarding retention in HIV care. This is a qualitative study with people that are living with HIV, with community pharmacists and social workers. All right, and for my acknowledgement, my advisor in the School of Pharmacy helped me with this project. I have a committee member, Betty Tuning, and then Professor Kristen Pekanik with the School of Nursing. And so these were the people that really helped grow my project and make it to the stage that I can present it to you guys. And so the outline today, I will talk a little bit about the background. My study aims the methods that I used, results, discussions, conclusions, the implications, and then finally, what future research. So background statistics about HIV, there are about 1.1 million people living with HIV right now. And of those people, at least 160,000 are unaware that they're HIV positive. And what I want to focus for this discussion is that about 91% of new HIV infections are transmitted from people that actually do know that they're HIV positive, but they're not receiving HIV care. And so about new HIV infections, there are about 40,000, roughly between 37 to 40,000 new diagnoses of HIV still yearly. And we see, there's disproportionate impact on Black Americans and Hispanics. They account for at least 69% of new HIV diagnoses. Although this is not addressed in my research, this is something that I hope to look at for my dissertation topic. So the goals of HIV care is really to end the HIV epidemic by 2030. And so that's in about 9-10 years. And for the stages of HIV care, we have diagnosis. So a person might first know that they're HIV positive, then be linked to care. And that's connected to someone that can introduce them to the healthcare system if they have not been, and introduce them to HIV care. Then they must start receiving HIV care. And that's when they start taking medications. My background in pharmacy really makes this exciting for me. And then retention in care is because HIV is a lifelong disease. A person living with HIV should always be receiving HIV care, should always be taking their medications, checking their HIV viral load and so on. And then they must be virally suppressed. And so my focus for my research is really retention and care. It's making sure that people that have received a positive diagnosis are linked to care, they're receiving HIV care, but most importantly, they're staying in continuous HIV care. But when we look at this diagram to my left, you see that only about 49% of people that are HIV positive are actually retained in care. So what we see most HIV care is people are coming in and out of HIV care, so they're not consistent with that care. So pharmacists actually are, part of HIV care because of medication therapy management, but we're starting to see what other ways can pharmacists help with HIV care. But social workers, more importantly, as early as 1981, they began offering specialized HIV care. And so School of Social Work really integrated HIV education in their curriculum. And then they started a Linkage Care specialist program, which was aimed specifically for social workers to take care, to link people that are living with HIV to care and ensure that they're getting the right resources. And so that's why social workers are an integral part of my research. And so my study aims are to investigate the patients, so people living with HIV, pharmacists and social workers, perspectives of barriers, access to care in the community. So is there an issue? What are the issues of access to care that make patients fall in and out of HIV care? And then the second way is really to explore ways in which pharmacists and social workers can collaborate interprofessionally to improve adherence to care for people living with HIV. So that adherence to care piece ties to their retention in care, as we want them to adhere to their care and always stay in HIV care. So the methods of this study, I adapted a patient-centered medical home model, and it breaks down, about 1, 2, 3, 4 outcomes that we see for people with HIV. And so we first starts with experience of people living with HIV. So their experiences with testing, what activities need to be done by healthcare professionals to improve their HIV care, what additional interventions need to be, patient-centered, coordinated care, and just initiatives that people, so pharmacists and social workers participate in to help people that are living with HIV. And then lastly, the outcomes is what do patients want to get out of their HIV care? What do the pharmacists and social workers, how does that align with national HIV goals? And then how can we really leverage patient-centered care to improve HIV outcomes? And then so the study design, this is a descriptive qualitative study design. We use semi-structured interviews for 1-hour interviews, either face-to-face or over the telephone for people living with HIV. And so this data collection happened between 2018 and 2019. And so there was that option to meet face-to-face. And then we audio recorded the interviews and transcribed them verbatim. So the study setting, this study was primarily done in Madison and Milwaukee. And the duration was between, for data collection, IRB and all of that was between August 2018 to 2019. Yeah, that should be 2019. All right, for community engagement, which is a huge part of this study, we explored Milwaukee HIV community. So I volunteered in local events, volunteered as panelists for HIV local gathering. I scheduled visits to community pharmacies that take care of people living with HIV. And then I used this relationship to diversify my recruitment methods. So it took me a really long time to really be engaged in the HIV community because I moved from Iowa, came to Madison newly. And so I really wasn't aware of that community. And so I really explored in depth, the key members of this community and then engaged with them as such. And so for patients, we use both, snowball and purposeful sampling. And so try to get some patients that are living with HIV to let us know of other people and then recruit them. And then for social workers, we use the Wisconsin Department of Health Services online listserv for social workers in Wisconsin that take care specifically of people living with HIV. And then for pharmacists, I use the AIDS Resource Center of Wisconsin. And so I reached out to pharmacists through that and was able to recruit through all of these diversified methods. And then for people to be included in this study, patients had to, have self-disclosed that they're HIV positive, be older than 18 years old, and then pharmacists needed to be working in a community pharmacy setting. As we might be aware, there's so many ways, so many places and settings that pharmacists can practice, but because this is more a community-based research, we want them to be practicing in the community setting. And then social workers had to be part of that Linkage Care specialist program where they specifically work with people living with HIV. So data collection, this is a sample of my interview questions. And as I said, I adapted patient-centered medical home model. And so experiences, I started by asking Linkage Care specialists, pharmacists, what are their experiences in taking care of people living with HIV? And then patients, what are their experiences with living with HIV? And so to build some rapport. And then interventions, what are the pharmacists already doing to take care of people living with HIV, and if they mention something, probe it even further, to understand how they provide those services. And then for activities, what are some support services that they have and what's lacking? And so, we're trying to improve linkage, retention and care. So we are kind of probing for what are some things that are missing. And then we also want outcome, what motivates you to do what you do for people living with HIV, and see in the future if there's a motivation quiz that can be added to this. And then for our qualitative study evaluation criteria, because this is a qualitative study, as quantitative studies have, some marks, there are numbers, there are ways that we can see, evaluate some rigor, but with qualitative study, it's a bit difficult. And so I put in, a lot of effort into literature review to find out what are ways that I can ensure that this, the qualitative study is rigorous. And so we had procedural rigor and which is just a descriptive general way of how the research was conducted, and then methodological rigor, and which I used for dimensions from the literature, which is credibility, transferability, dependability, and conformability. And so procedural rigor is initially, as I mentioned, I immersed myself in the HIV community. So I understand that I'm an outsider practicing as a pharmacist. And so I came to understand, through going to HIV 101 meetings around Madison, I'm going to the AIDS Research Center in Wisconsin, and also going to the Center for AIDS Intervention Research monthly conference in Milwaukee. And then I also presented study plans to conferences around the US. And so I was in Georgia, I was in Indiana, I was also at some here locally in Madison and at the Society of Behavioral Medicine, and just try to look for additional input, and also from the American Pharmacists Association. And then for the methodological rigor, I established a relationship in non-research settings, and also the semi-structured interview nature made it open so that people can provide me with information, use probes, allow participants to go over an hour if they needed to. And also, I also specifically use member check-in to come back to them and ensure, does this accurately describe what you've been saying to me? And then, checking to see if my findings are paraphrased through what the other person is saying. And then transferability, I try to use several recruitment procedures to reach a diverse population. And I ended up using a very small sample size because we reached that saturation, but we made sure that some minority groups were included in the data. So we had men who had sex with men, people that had English as spoken language, and then we had Black and African American representative in our data. And as I mentioned earlier, when we were looking at the disproportionate number of African Americans and Latinos that are impacted with HIV, this was very important to the study. And then conformability, when I was conducting the data analysis, I made sure that consensus was reached on each team and called by the researchers that were doing the data analysis. And then I tried to bracket my own preconceived notions during interviews and not lead participants on. And then dependability, I made sure that there were audio recordings were de-identified, and then the transcripts were transcribed by a UW certified transcriptionist. So for the data analysis, I use both inductive and deductive content analysis, and then a statistical software and Vivo, which you might be familiar with. I absolutely love using in Vivo. And then lastly, for the results, so we ended up having using 5 patients, 5 social workers, and 5 pharmacists. So a total of 15 participants, which is okay for deductive and inductive content analysis. And so these are our sample. And then for categories of themes, so for experiences, what are people's experience and perceptions of HIV? We started finding barriers to HIV care. So there were individual level barriers, systemic barriers, and then limitations of the Linkage Care Specialist program that the Linkage Care Specialists were part of. And then for activities, there needed to be an established role of pharmacists in HIV care, building of rapport, creating a safe space in community pharmacists, and protecting the privacy of patients, and also leveraging relationships with clinicians around the environment. So these were the things that our participants, would be done in the community setting to help in retention with people living with HIV. And then there are some additional interventions that they needed for community pharmacists and social workers to work together and address. And then these are addressing health disparities in HIV care, target young population, provide comprehensive HIV care, which was very related to the experience section where we see those individual level barriers and systemic barriers. So HIV care should be more comprehensive. And then there was the concept of drug holidays where patients just got tired of taking drugs. And so how can social workers and pharmacists come together and help with that? And then referring patients, community resources, also just generally collaborating with the Linkage Care Specialists. And then PrEP, of course, providing HIV prevention services. And then the outcomes, some of the outcomes that were, stood out to us were patient exposure to HIV care. So some of the patients explained that actually having HIV was their first exposure to the healthcare system. And so that's that's something that I hope that we can look at in depth is what then are we, So they're living with HIV, so it's a really complex disease, but that's their first time really interacting with the United States HIV system. And some patients actually felt empowered by their HIV positive diagnosis and found themselves becoming advocate for people living with HIV. So I will try and go over the themes. So theme one, and provide us some sample quotations as time permits. I have about 18 minutes, all right. So there is HIV care in the community settings, and then theme two is limitations of linkage care specialist program, and then the challenges to pharmacists providing HIV care and recommendations for pharmacists to provide HIV care, and then interventions. So we had stigma, mental health, substance abuse and misuse, homelessness, food insecurity, and cost in insurance coverage. So for stigma, these are some of the quotations that we had. And so SW means social worker, and then PLWH is person living with HIV. So, someone said if they're newly diagnosed, they might become homeless because they're living with family, and family, won't take kindly to hearing this information. So stigma might be something that impacts a person's retention to care. And then there is also shame. The social worker mentioned shame and guilt in addition to mental health. And I do not have the time to go over all the codes, but I would just, have us pause on the screen and just look at them. And so mental illness, another patient living with HIV said, they experienced dark depression for 2 years and wouldn't come out of their house. And so during that period, that's a period of lost retention to care if they're not interacting with others and the healthcare system to, take care of their HIV. And then a social worker says if someone has a cognitive delay or chronic persistent mental illness, they make them more at risk for HIV acquisition and then poor adherence to HIV care. And so this is with mental health, it's almost a double-edged sword. And then homelessness is still a big thing that we are trying to improve with HIV care. So there's a lot of housing concern, and CP is a community pharmacist. And so we have a fair amount of housing concerns. Sometimes, obviously, if you go from a hierarchy of needs standpoint, if you're not stably housed, meds are probably not the first thing on your mind. And then limitations to linkage care. And so that's the Linkage Care program is the program that social workers are part of to improve HIV care, to improve linkage to HIV care. And I know some of us just joined us, so part way I might be using language that is not, well understood by all, but I would try my best. And I will just quickly add the chat. Okay, sorry. So thank you, Lisa, for joining. So to be part of Linkage Care Specialist Program, there is strict patient eligibility requirement. The duration of the program is really short, and then there's unsustainable solutions to HIV care. So strict patient eligibility. And so social worker said, when I introduce myself, I tell them that I'm not with them forever. So she starts with that. It's like, should be part of her role, because some people are like, are you leaving me? And it's really hard for people to transition once they start meeting linkage. The Linkage Care Specialist program was last only about 6 months. So you're going to be living with a chronic illness for the rest of your life, and then you just have this support for the first early 6 months of your diagnosis. And so a pharmacist said, she's talking about a patient, Linkage Care Specialist. Well, I'm not going to be able to help you. I said, really, why? And she said, I'm going to tell you exactly what she told me. Well, you're not homeless, you're not a drug user, and you're not a whore. And so as such, I don't really have to help you. So we see that the Linkage to Care Specialist program is almost reserved for people that are homeless or have really some other criteria that they have to check out to be part of the program. So someone that just became HIV positive might not fall under all of those umbrellas, so they're missing out on this specialized HIV care. And then the transient nature, Linkage to Care, as the social worker on the right said, it's a short-term program. So really we're discharge planning the entire time that we're working. And so if you've worked in a hospital setting, you understand that this discharge planning is, once a patient comes in, it's like you're just creating a way for them to leave, like make an arrangement for their leave. And so there's not that settlement and absorption into the program. And then there really are some unsustainable solutions to HIV barriers through the Linkage to Care specialist program. We see a social worker say they're not able to transport a patient, and then another social worker says their patients are getting kicked off food share and facing more food insecurity because the program is not sustainable. And then next, what are some of the pharmacist challenges to HIV care? We have a lack of an established role for pharmacists in HIV care. Patient advocacy is viewed outside the scope of pharmacy practice, and then prior negative patients' experience in pharmacies hinder them from staying engaged with their HIV care. So the social worker says, we social workers are kind of like the thread that weaves through the patient's life and their medication and their primary care and their specialty. And then the pharmacist is like more narrow in the picture and also can't do anything about it. And I think, that's where social workers come in. And so you see that the social worker is more aware of their role, and pharmacist is almost a glimpse of HIV care. When HIV cares, we see, to get a patient to be virally suppressed, and earlier on, as I described, that's the last stage of HIV care. They have to be on their medication constantly. So a social worker said, I don't think like the rest of the care team understands how important the pharmacist is or the pharmacy is, because they're every month-to-month contact with the patient, where once a patient becomes virally suppressed, a physician might not see them unless for half a year or something like that. And so there's that opportunity to see pharmacists, but it's not really like part of HIV care. There isn't that established role for pharmacists. And then, the social worker says, when you think pharmacists, you think pure medication. And then patient advocacy is viewed as outside the scope of pharmacy practice. And so social worker said a pharmacist can play the role of a social worker. And when she went on to further explain that, she talked about patient advocacy, but it's termed as social work rather than pharmacy practice. And then a pharmacist said, so I would see an injustice that I felt like people weren't getting proper care or they weren't, getting help from their insurance or whatever. So I can become a bit more of a social worker myself. And so even that pharmacist is identifying her role as being a social worker and not really a pharmacist, but it sounds like it's within her scope of practice. And then we have patients that have had prior negative experiences in the pharmacies. And so a patient living with HIV says, and sometimes a lot of the times the pharmacy staff are respectful and courteous and professional. So that's another reason to avoid the place. And also another pharmacist said, we've had people transfer their med into this pharmacist because they live in rural communities and then their privacy, was not respected. And a patient said, I do not want to be seen because of stigma and breaches in confidentiality. And I know someone that has experienced this in small towns and people gossip. So then the last thing, one of the things is recommendations, nonetheless, for pharmacists to provide HIV care. So we have build rapport with patients, create a safe space for patients, and then hire diverse community pharmacy staff, and then become familiar with community resources. And so these are some of the things that we pick from, our stakeholders, and they were like, well, how can pharmacists provide better HIV care? And these were some of the things that they provided. So building rapport with patients is really important. And so social worker says if you're getting a phone call from a pharmacist you've never met, and it's more difficult to have those trickier conversations than maybe someone you've seen. And then hiring a diverse community staff. And I know this can be, more in-depth hiring and also retaining a diverse staff and work with diversity in different pharmacy settings. And so a patient said, there was just one Black person working at a pharmacy that's there, and they're not reaching as many people as possible for that reason. And then a patient said, having a gay community pharmacist working was really helpful for them, because they didn't feel isolated. And then another patient living with HIV said, but with trans people, you have to work this fine line. So be very respectful and so on. You have to learn how to interact with those people. And so that would help in the pharmaceutical industry to have people that are trans. So that was what their quote further went on to say. It's important to have those people in pharmaceutical industry. And when I checked back with them during member check-in, they meant a pharmacy to have those diverse people to help. And then become familiar with community resources. And so the patient living with HIV said, told us about a 24-hour shelter in United Ways that pharmacists can become familiar with in their role. And a social worker says, if someone presents with a social or mental health barrier, going the step beyond and saying, here are some resources that, in the community that would help. And because these are community pharmacies, this was such an important theme for them because you practice in the community. So you should be able to be aware of the resources around you. So it's not an isolated, practice. It's really within the community. And there's that opportunity for you to become for pharmacists to become familiar with community resources and provide them within their pharmacy. And then additional interventions to improve HIV care. So addressing health disparities in HIV care, targeting younger population, educating patients about drug holidays, and then providing HIV prevention services, as well as empowering patients. So address health disparities in HIV care. So for community pharmacists, I do also believe that there is probably a disproportionate amount of insurance barriers for a lot of folks because of just the differences in diagnosis for lower socioeconomic status and people that maybe don't have a stable income or insurance resources. And then, then we had another social worker say, we know that young men who have sex with men of color are, the highest infections rate that we're seeing. And we're trying to help test them more and because they have the more prevalence. So addressing these differences in disproportionate HIV diagnosis. And then younger populations, since their social work said younger people don't have a previous or a chronic condition or have never taken pills before, So because they're so young, they're healthy, right? And then this is their first introduction, to the medical care. And so really making sure we're focusing on those younger populations because it's their first time and this is, a big condition for them to live with. And that was just one thing that the social worker on the left is saying. And sorry, I really have to be respectful of time. So as much as I love reading these codes, I might have to skip a little bit more further. And then drug holidays, as I mentioned, is when patients just become frustrated and stop taking their medication. And so pharmacists are saying there's really a need to educate patients, understand why does that happen and how can we help with that, not really some of this varies to patient holidays, such as, several pills a day. There are fewer pills for patients to take right now with people living with HIV. And then providing HIV prevention services. Pharmacy staff can become well educated in prevention. And so actually another student in our lab is working on educating the community through pharmacies about PrEP, that's prevention medication for HIV. Then empowering patients, and her social worker said the most rewarding thing for her is knowing that one of her patients is getting married, is moved out, and so on, and able to take care of their health. And then so next with discussions, that we have 6 minutes, and so our first aim again is to investigate patients, pharmacists, and social workers' perspective barriers to access HIV care in the community. And so there is a need to improve the pharmacy profession by contributing to public health efforts to improve health outcomes for people living with HIV, and then the use of screening tools in pharmacies to understand the patient barriers that we discovered from just this additional discussion with our stakeholders. And then they can become familiar with resources within the community and advocate for patient needs. And then patient barriers to care, homelessness. Pharmacists can be familiar with the patient burden of homelessness and tailor their counseling accordingly. And so, when I was in pharmacy school, we learned, tell them where to put their medication in the home. And so it's not a lot of our patients that have a home. And so, some of even our counseling is tailored towards a different and entirely different demographic. And then this is stigmas already addressed in pharmacy schools and training of pharmacy staff, but this is something that can be further honed in the pharmacy setting, most especially because patients did talk about feeling comfortable in the pharmacy setting. And then pharmacists and barriers to care. And so there can be a transition in care from the Linkage Care Specialist Program. That's what social workers do. They can become more aware of what type of care a patient is receiving. And then during that duration of lapse of care, be connected to a pharmacist. And then they can utilize this information from social workers to understand how best to approach care for their patients. And then there's also a need for pharmacists to have some of more representative staff. who have lived experiences with patients. And then explore ways in which pharmacists and social workers can collaborate interprofessionally to improve adherence to care for people living with HIV. So some of the social workers talked about how they can be present in at the pharmacy for pharmacy intake or other patient or pharmacist visitations. This does not traditionally happen. There's usually pharmacists will communicate with the social worker, pharmacists will communicate with the patient and vice versa, but there isn't really opportunities for these three important groups to come together. And pharmacists and social workers have also discussed or can keep on discussing if it's feasible for them to participate in home visitations. And so social workers do go to patients at home, and we explore if pharmacists can do that, because pharmacists already do that for different other healthcare. When I was in my pharmacy training, I know that I did some home visitations, and we can see that's also visible for people living with HIV. And then explore integration of the pharmacy professionals into existing care models. So when I looked at a lot of care models, it usually has social workers, but it really misses out on the pharmacist perspectives. And so in conclusion, there is a need for pharmacists to become more visible in HIV care by catering to patient needs and connecting patients to community resources. Pharmacists can also collaborate with social workers to focus on younger and marginalized HIV patients. And then some limitations to this study. I would start off with mentioning the study strengths. So these are perspectives of different informants. This study was guided by a conceptual framework. And then there was really procedural rigor in ensuring that I was part of the community, and the way that the data was collected and analyzed was also rigorous. But of course, there's also limitations. So the focus group for cohesive communication is needed between pharmacists and social workers, because these were all isolated interviews. And then our largest sample size could be used to reach other patient population. And then the sample was from a Midwestern state. It was from Wisconsin and just in Madison and Milwaukee. And then implications. So pharmacists are eager to advance their profession beyond medication therapy. And so this is really an opportunity for pharmacists. This is one of the first studies. This is the first study actually to highlight a need for pharmacists to focus on patient barriers to HIV care. A lot of other pharmacy studies usually only focus on medication adherence, because as we see, there's so many things going on. As one of the pharmacists said, if a patient is homeless in their hierarchy of needs, then medication is probably not what's in their mind. And then this study provides more information about the Linkage Care Specialist Program and a possibility for it to be integrated into the community pharmacy setting. So further research can recruit and engage more diverse study participants, and then design and test interventions can happen in the community pharmacy settings that test that collaboration with social workers in addressing patient barriers to care. And then also importantly, we're given so many recommendations, but reimbursement, is an incentive, and fear, of course, also. And so explore reimbursement models of successful interventions, especially between the pharmacists and social workers, who would pay for their time. If the social worker decides to come to pharmacy visitation, who would pay for the pharmacist's time that they decide to go for home interventions. And so we want to see, first they have to be successful, and then we'll see how can they be reimbursed for their time. And so these are my references. With that, I want to thank you all for listening. And I'm open to questions or comments. I know there are just so many pieces to it, so I'm really looking forward to what you have to share. Thank you.
I don't know if you can hear me okay. I just wanted to say I really appreciated your talk. It was amazingly well organized, and really helped me think in a really systematic way about how you would go about doing any qualitative research. So I really appreciated that, and very valuable, but also just so well organized and thought out.
Thank you. Thanks, Patty.
This is Erlise Ward, Adati. I also want to express the same, to say thank you very much for sharing your important work. I learned a lot, so thank you, thank you. The context of social work is working very closely with pharmacy, certainly a new concept, and I certainly see the value in that type of relationship. The one piece I was just sort of wondering about is, might there be a role for for patient advocates? And because it sounds like pharmacists are saying, well, that's not what we do. I mean, we practice, with medicine, that's not what we do. Social workers are able to kind of take some ownership in that, but there's still sort of some gaps. So I was just sort of wondering about, might there be a role there for patients and how that might help to bridge the gap somewhat?
Thanks so much, Elise. Thanks for being here as well. Elise is my advisor's mentor. She's here. So you really bring up an excellent point. I had not thought of patient advocates, but there's definitely a role that they could play in that, it really, especially with the reimbursement part of it, I know that then, that frees up the social workers and pharmacists' time and also puts in people that are more, maybe have a lived experience and have a bigger incentive just to care for other people living with HIV. So I would explore that further. Thank you.
You're welcome.
And as I said, I'm doing this to also explore my dissertation topic. And so if there are some things that you are thinking, I really would be curious to know more about that, so feel free to share if there's like parts of the presentation or some things that are unclear and you think that maybe perhaps this is worth further exploration.
Well, here's the one thing, since your dissertation. So the study that you shared with us, you used a qualitative approach. I'm just wondering about the possibility of mixed methods where you might design a survey and you'd be able to get input from a larger sample, possibly a national sample, and then still incorporate the qualitative piece in there. And with all of the technology now, I mean, we can interview people in wherever they are. So I just wonder about, as you move forward, because this is new research, and kudos to you. You're saying this is the first that we've done this. This is the first that we're, learning about this. And I see the potential of this work. So just kind of thinking, in the future, larger mixed method design studies. And I know your advisor, she's all about mixed methods. So you have the resources that you need to help you kind of think about advancing in that area.
Yeah, so definitely. Thank you, Elise. That's an excellent point. I thought about mixed methods as my advisor has expertise in that. And so I am definitely exploring mixed methods and, doing a survey of some sorts, but I'm still trying to narrow it down, what part of this is well, important, timely, and also feasible for me to graduate as well. And so definitely exploring that.
Well, think about it in the context of building your program of research. So what I just suggested, that can be after you graduate, the next study, okay?
Yes.
Because we do want you to graduate on time.
I guess a question that I had is, as you're kind of thinking about topics to continue exploring, from the participants that you worked with, what do you think were the top priorities for them to keep exploring, or things they wanted to learn more about, questions they had, problems?
Okay. So another limitation of the study is that the participants that I had were more affluent because of the way that I recruited. So I met them at some of these 101 HIV, 101 HIV presentations that are happening around Milwaukee, Madison. So a lot of them had their viral loads under control. And so they probably were not able to provide the best purview of people that are still struggling to manage their disease, which are people that I really hope to reach in the future. And so I think some of the things that they talked about from their experience, especially one of the participants, is that concept of drug holiday. It was my first time hearing it. And so when I checked and I asked, I learned that a lot of patients actually do that. And it's just wake up and give up and say this is too much, but they term it as a holiday. And so really see it as a positive, it's a drug holiday. I just need a break from this. And so also as a pharmacist, this is then something that I think it's of importance. And the other thing that I didn't was not able to present about is also the issue of substance abuse and misuse, which is also very prevalent in HIV population. I was at a conference last week, and they talked about that. But in my study, they talked about it as linked to housing, because then if you're homeless and you're used and you're in your active addiction, then you're not eligible for housing and also other of the HIV resources. And so that provides an even bigger patient barrier. So those are the two things, are drug holidays and substance abuse and misuse. Thanks, Haley, for your question. And so another thing that I wanted to point out was when I did this study, and they talked about, diversity in the pharmacy staff. So I know last year has heightened our, at least for me, my knowledge and understanding of diversity. And so when I even presented, I just thought, put more, just hire the staff. And so I'm interested in the just pharmacy workforce, if, you don't just put in a patient that maybe identifies as, part of maybe the LGBTQ community, or patient for a technician or pharmacist from different socioeconomic barriers. Is the pharmacy environment conducive? Is it supportive to retain, those people in HIV care, or someone that's HIV positive? And so, I had to start rethinking that, because I thought, well, just, hire more diverse staff, but that has now a deeper meaning and more dimension to that for me. Is, what does even diversity in the pharmacy workforce look like now? And it's a predominantly white female profession, and the staff is similar to that. And so I wonder, how will then the marginalized population fit in? And will they then be hired just to look diverse? But what are the company values that align with that? And so that's one of the part of the research that I'm now thinking. Well, I hadn't really thought a lot about that, and so I'm grateful. I mean, the last few months, or the last year especially, has really been really hard on marginalized communities. But then there's this more knowledge and education that I hope has come out of it, and I hope to address it in future researches, to look at it more and understand it better.
Adati, thanks for sharing your thoughts on this critical area. And like you said, in the pandemic, it just really heightened those issues. And so, across different disciplines, we are certainly talking about that, the need to diversify the healthcare workforce. I know in the School of Nursing, we've been talking about that long before the pandemic, but certainly heightened at this time. One place, again, I come back to the community or sort of patient advisory board. So really thinking about sort of that concept, because what you're talking about in terms of, diversifying sort of the pharmacy workforce, the importance of having pharmacists that look like the patients that they're serving in all of the different ways in which we are diverse, right? And thinking about what that may look like, I think having a patient advocacy board, they can really give information, good information in those areas that might help to begin to advance the field that way. So give that some thought. And there's, we're seeing growing research in that area around patient advocacy groups, community advisory boards, and your advisor, she's doing work with those groups as well. So I think just sort of thinking through that some more to see where that may fit for you. And if you may even have a research question after you graduate, of course, in that area.
Thank you, Elise. Definitely, thank you. I have taken note of that. I'm even thinking as just something even to be done in the interim is really exploring that aspect of patient advisory board and what their understanding of diversity in the pharmacy workforce could be. All right. Are there any other questions or comments from the rest of our panel? Haley, is it okay to give them back the 5 minutes?
If not, yeah, I think,
Okay.
thank you so much. That was so much information and such a, yeah, I learned a lot. I think everyone else did too. And I really appreciate you sharing your time with us. And thank you to everyone else who's able to join and learn more. And we will be able to post this on our website, and I'll make sure to share that with you, Adati, so that you can share with your networks as well. But thank you so much for sharing and for your time.
Thank you, everyone. Thank you.
Thank you. All best wishes.
Yes, happy almost end of the semester. We're almost there.